Yes, sir.
Yes.
Joseph sir has also joined. Sir, good evening.
Sir, we
Hi,
are
hi.
going sir, we are going live in three, two,
Yeah.
1. We are live now.
Okay. No, sir, you can start.
Good evening, ladies and gentlemen. A very, very warm welcome to each one of you. Today is auspicious beginning of something which is about to unfold into something wonderful. It is titled Blood. We all know blood is the life savior. It's the back for everything that we do in our life. We are extremely grateful and thankful to our mentors, our course directors, Professor Dr. Biju George. We know him very well. Professor at the Department of Clinical Hematology at prestigious CMC Hospital, Vellore, and Professor Dr. Joseph John, Professor and Head Department of Clinical Hematology at prestigious CMC Hospital, Ludhiana. Words is not enough, sir. We really, really thank you on behalf of all these students and all the senior residents and all the consultants in the field of hematology today. Friends, this web series, which will be hosted on third Wednesday of every month, will be short and sweet. It will be just for a period of 1 hour. It is dedicated to the field of hematology, rare disorders, its advancements, and those of us who would be completing all the episodes and will be attending and participating will also get a certificate of participation. And that's not all. At the end of 24th session, there is also going to be a quiz, and this quiz will be from the portions and the case discussions which happened during these 24 episodes. And there are academic grants, third at 20,000, second at 30,000, and the first one at 50,000, basically to act as a motivator. Today's first debutant is from the Department of CMC Vellore. All this has been achieved by our mentors, our course directors, and it's my honor and privilege to briefly introduce someone who is dear to all of us, known to all of us, Professor Dr. Biju George. We know him, he's Professor and Department of Clinical Hematology at prestigious CMC Hospital, Vellore. More than 296 publications in Journal of Repute, Scopus Index. He has contributed 6 book chapters in publications, including focusing on hematology and stem cell transplantation. What he worked on at the beginning, fludarabine and cyclophosphamide, today for aplastic anemia, is now a national standard. He has initiated over 200 plus haploidentical transplant at CMC Vellore, developed specialized transplant protocols for Fanconi anemia and other congenital disorders. Dr. Biju George's area of interest is stem cell transplant and infection management and bone marrow failure disorders. Our second program director, Professor Dr. M. Joseph John, Professor and Head Department of Clinical Hematology at prestigious CMC Hospital, Ludhiana. More than 30 international, 38 national publications. He's been part of 7 book chapters in prestigious national and international publications. He's been principal investigator in more than 20 plus clinical trials. Many awards and accolades to his credit. I can go on, but just to mention very briefly a few: Scott Gold Prize 2024, Dr. Vijay Satija Memorial Award 2023, ICMR NIH Oration Award 2022, FICH Fellowship in the year 22, Best Team Award 2022. Key contributions has been many. Just to mention a few, he established clinical hematology and stem cell transplantation service at CMC Ludhiana in the year 2008, founded Comprehensive Hemophilia Care Center and later a Center of Excellence in the year 2010, pioneered first successful stem cell transplant for leukemia in Punjab, and launched DM program in clinical hematology in the year 2019, and innovation services like home care and mobile phlebotomy. Sir, thank you for agreeing to be a part of mentor for so many budding hematologists of the country. May I request you to formally inaugurate this, and nothing could be as better than slokas and chantings to begin this. Over to you, sir. May I request you to inaugurate this first?
Sir, yeah. Dikshan,
Support, please start the video.
Sure, ma'am. Just 1 second.
It's a virtual inauguration with kind permission of Viju George sir and Joseph John sir. Over to you, the support for the video, please.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Welcome to this interesting web series.
शुभं कुरु त्वं कल्याणम्
May I request our program directors, Biju sir and Joseph sir, to take it forward from here. Over to you, sir.
Thank you very much, Dr. Manoj. And dear friends, welcome to this first of many web series that we are planning to have across the next 24 months. What we hope to do is to involve different institutions to present their own experiences in different aspects of hematology so that it becomes a learning exercise not just for residents and students but also for doctors and hematologists who are in clinical practice. So we will be starting this off with the first case which we are going to be presenting, and the format is going to be essentially it will start with the case presentation, which will be followed by a discussion by one of the consultants, and then we will give final comments. That after that, I hope we will have enough time so that we can take up a few questions if you have any on this topic. We hope that over the next 24 months, we will be able to deal with 24 different topics in hematology so that over the next 2 years, you will have a reasonable, good look through different problems that we see in hematological practice. So we are going to be concentrating on aplastic anemia and look at some of the problems that we actually face now in aplastic anemia, especially when we are managing children with the kind of technological advancements that we have. So sometimes technological advancements may not be a boon, but rather cause more trouble in our thinking, and that is what we would like to present. So I would request for the presentation to be started. Dr. Yash, who's a DM resident, will start with the presentation. Yash, go ahead.
Thank you, sir. Am I audible?
yes,
Yes,
you are
yes,
audible.
go ahead.
Is the slide visible?
Yes, please go ahead.
Yes, it's visible.
Good evening, everyone. The topic for today is hematologist search for stem cell donor. So there was a novel called A Man's Search for Meaning, which was written by Mr. Viktor Frankl. He was one of the Nazis. He was one of the prisoner in the Nazi prison during the World War II, and he was searching for meaning in a man's life. So this is very, very similar to a hematologist search for stem cell donor, which will come through in the next few slides, whether to take an HLA matched donor, an HLA mismatched donor, a haplo donor for a stem cell transplant in a case of aplastic anemia. So I'll briefly go through a case which we had in our institute just a few months back. So he was a 16-year-old boy, a class 11 student from Bihar, who presented to us in July 2024 with complaints of fatigue for 3 weeks, which was on and off since June 2024. There was no history of fever or any bleeding manifestations, no history of loss of weight or loss of appetite, no chest pain, cough or breathlessness, no other complaints except the fatigue. So he was initially evaluated locally in Bihar itself in June 2024 and was found to have pancytopenia. The baseline parameters revealed an HB of 5.5 with a retic of 0.5% and MCV of 80 femtoliters. Total count of 2,500 with 30% neutrophils, 68% lymphocytes, and a platelet count of 9,000. Bone marrow was done, which was suggestive of aplastic anemia. He was transfused 3 units of packed cells and 3 units of random donor platelets and started on tablet danazol and cyclosporin. After about 2 weeks, that is in July 2024, he came to CMC for further evaluation. So he was a second born of a non-consanguineously married parents, and there were no perinatal complications. The developmental and immunization history was not significant. He had an elder sister who was 17 years old and doing well. His mother was diagnosed with aplastic anemia, who underwent matched sibling donor allogenic stem cell transplant in 2022 at our institute. She had a primary graft failure and she expired post second matched sibling donor transplant with the same donor on day plus 14 due to sepsis and probable fungal brain abscess. So I'll just briefly tell you about the mother's history. She was a 35-year-old female who was diagnosed with severe aplastic anemia in October 2021. NGS wasn't done at baseline. Her brother's HLA was 12/12 matched with her, and she underwent a matched sibling donor allogenic stem cell transplant on 29th of January 2022. She had primary graft failure, so she was planned for a second allogenic stem cell transplant with the same donor, which she underwent just in about a month, that is on 26th of February 2022. However, she expired on day plus 14 of the second transplant due to sepsis with a probable fungal brain abscess. So the first transplant details of the mother, the conditioning regimen used was fludarabine plus cyclophosphamide. The CD34 cell dose was 8 into 10 power 6 cells per kg. GVHD prophylaxis used was PTCY, that is 50 mg per kg per day on day plus 3 and day plus 4. And complications included CRO, Klebsiella pneumonia sepsis, probable fungal pneumonia, herpes simplex skin infection, and hepatic dysfunction, very drug induced. Subsequently, she developed primary graft failure and was planned for second transplant. So the second transplant details, the conditioning regimen was flu TBI, fludarabine with 30 mg per meter square per day for 3 days, and TBI of 200 centigrade. CD34 cell dose was 10 into 10 power 6 cells per kg. GVHD prophylaxis was cyclosporin from day -1. Complications included bleeding manifestations, GTCS, probably hypoglycemia related, enterococcus sepsis with septic shock, and a probable fungal brain abscess. She expired on day plus 14. Coming back to our patient who presented to us in July 2024 and was diagnosed with aplastic anemia. On examination, he was vitally stable, pulse of 80 per minute with a blood pressure of 110 by 70 millimeters of mercury. He was mildly pale. There were petechial spots on bilateral upper limb, lower limb, and trunk, but no morphological features suggestive of inherited marrow failure syndromes. There was no hepatosplenomegaly or lymphadenopathy. Other systemic examination was unremarkable. On evaluation at CMC, we confirmed the diagnosis of very severe aplastic anemia. Based on CBC parameters were HB of 7.9, total count of 2,400 with a platelet of 14,000. MCV 89, a differential count on 50 cells revealed 1 neutrophil, 48 lymphocytes, and 1 monocyte. His reticulocyte count was 0.25%. Renal and liver function tests were normal. Bone marrow done outside was reviewed, aspirate was dilute, and refined biopsy showed markedly hypocellular marrow with the 10% cellularity and a markedly reduced trilineage hematopoiesis suggestive of aplastic anemia. His stress cytogenetics or chromosomal breakage analysis was not sensitive to mitomycin C. However, there was increased chromosomal breakage in response to mitomycin C with a score of 18. So FANC D2 ubiquitination analysis on dermal fibroblasts was suggested, which was carried out. On the skin fibroblast culture, the ubiquitination of FANC D2 by Western blot was normal. I hand over to Dr. Newton to briefly talk about the chromosomal breakage analysis.
So, what we do in the chromosomal breakage analysis is we see the fragility of the chromosomes. It is also called as stress cytogenetics. So, the indications here are if there is any young patient, usually we keep a cutoff of 40 years for checking for inherited bone marrow syndrome in a patient with aplastic anemia. Those who are younger, even without the phenotypic abnormalities of Fanconi, we should check for chromosomal breakage analysis. Or if there is a significant family history of bone marrow failure syndrome, we should check it. If there is unexpected occurrence of malignancy, which is common, which is classically seen in Fanconi's anemia patients, like head, face, neck, squamous cell carcinomas, or carcinomas of esophagus, vulval carcinomas, or cervical cancers. So in those cases, chromosomal fragility test should be done. Sometimes in acute leukemia patient post chemotherapy, if they develop the excessive toxicity for a standard dose, then also we should go and check for this chromosomal fragility test. So what we do here is we see the sensitivity of these chromosomes, we arrest them in the metaphase, and we see the sensitivity to mitomycin or DEB. So if at all if the patient has received recent chemotherapy, it can be done on the fibroblast also. So this was considered as gold standard for diagnosing Fanconi anemia until recently. However, NGS definitely helps us in recent years more. Next slide. Next slide. Yeah, so this is what we see under microscope when we do the chromosomal breakage analysis. Just slide before. The previous slide. Yeah, so if you can see the first slide, these are the normal metaphases. The second slide, it shows the chromosomal, it's just a break in the chromosomes. However, these chromosomes there are no triradials, which you can see only in the third slide. If you can see, there are these chromosomes which are forming the triradials, those which are rounded in the circles. So those are the ones which are triradials, and only those are counted when we calculate the score for the patients in this chromosomal breakage analysis. Next slide, please. So if we, so there is a specific formula. Next slide, please. So there is a specific formula. Basically, we analyze the 40 metaphases, and we from that we calculate the we check all these triradials, and we calculate from the formula the score. Usually, score more than 40 is considered as significant. So for our patient, it was 18. It means it was not conclusively less score. The score usually, can you just get back to the previous slide? Okay, so yeah, so if it's a score up to 15, we say that it is not sensitive. It's completely that there is no, it's not sensitive to mitomycin. However, score more than 40 is considered as a significant score. The scores in between are usually borderline, and they need NGS. We usually do NGS for those cases to confirm. So next slide, please. So there is the next slide. We will see the what is the Fanconi anemia, the previous slide. The previous slide, yes. Yeah, so this is a Fanconi anemia DNA repair pathway. So what happens usually, this Fanconi anemia, whenever there is DNA damage, usually first the the ATR gets activated, and with that, the DNA damage, the ATR gets activated, and it activates the complex 1, which includes different chromosomal, which includes different proteins like FANC-A, FANC-C, FANC-G, and many more. So that is a complex 1. So once it gets activated, it in turn activates and ubiquitinates the FANC-D2 protein. So FANC-D2 protein, once it is ubiquitinated, it with the help of complex 2, it forms a DNA damage inducible repair foci. And that's how the DNA is repaired. So whenever there is a problem in this FANC D2, that is this protein we detect by a method called Western blot. So that is the Western blot. So that is the another way of checking. That is the another way of find the diagnosing the Fanconi's anemia. Next slide, please. So if we in this Western blot analysis, we are looking at this FANC-D2 gene. So mutations which are upstream to the FANC-D2 gene can be detected, or if the mutations in the FANC-D2 gene itself or the one which are upstream to that can be identified with this method. However, the mutations which are downstream cannot be detected. So next slide, please. Next slide, please. Yeah, so if you can see here in the diagram, these are the proteins which we detect on the Western blot phenotype. The FANC-D2S suggests the unubiquitinated form of FANC-D2, and the FANC-D2L suggests the ubiquitinated, monoubiquitinated form of FANC-D2. So if you find the unubiquitinated form, that is FANC-D2S, but L is absent, that suggests that the mutation is upstream. If both are absent, it suggests that the mutation is in the FANC-D2 itself. And if you find the both, it means that either it is a normal pathway or there is some somatic mosaicism, or it's some other chromosomal breakage disease. Next slide, please.
So coming back to our patient, the diagnosis, prognosis, treatment options, costs, and outcomes were discussed with the family. They were willing to explore allogenic stem cell transplant as the best available treatment options. HLA was sent with the sister. He was found to be a 12/12 match with the sister. NGS for inherited bone marrow failure syndrome was sent for the patient's sister as well, as there was a family history of aplastic anemia. He was planned for match sibling donor transplant with sister as the donor and was being worked up for the same. So this is the HLA report of the sister who was a 12/12 match with her. Meanwhile, NGS reports for both the patient and the sister were ready, which brought a twist in the case. So there was a variant in heterozygous state which was identified in exon 18 of SRP72 gene, which was of uncertain significance, and it was a missense mutation. So SRP72 gene, as you can see, the one highlighted in the red box at exon 18, there was a variant in which glycine was replaced by arginine, and it was a heterozygous mutation which had autosomal dominant inheritance.
Yeah.
I'll hand over to Dr. Nutan to brief about SRP72.
Yeah, so SRP2 gene is a protein coding gene. This gene is it encodes 72 kilodalton subunit of signal recognition particle. SRP stands for signal recognition particle. It mediates the targeting the secretory proteins in the endoplasmic reticulum. Basically, it has three functions. One is a translational arrest. That is, it helps in translating the proteins that are destined for the cell membrane or the extracellular secretion. It also helps in protein targeting and trafficking. It helps to move the proteins to the correct location in the cell. So the mutations of this gene are associated with familial bone marrow failure syndromes. Next slide, please. So, so far, this Kirwan et al. In 2012, there is one publication where they have identified two families with this mutation, which they have found to have this mutation with aplastic anemia and MDS patients. So there was this first family wherein 4 members were affected with autosomal dominant bone marrow failure syndromes. and they found a heterozygous truncating mutation in this SRP72 gene. Mother had myelodysplasia. 3 children between for 11 to 14 years. All of them had aplastic anemia or pancytopenia. Mm. However, all these four family members also had congenital nerve deafness. There was another family wherein mother and daughter were diagnosed to have myelodysplasia without any somatic defects. However, none of these 6 patients require any treatment though. So this was the mutation wherein in exon 18, glycine was replaced by arginine at 601 position. And heterozygously it was a missense mutation which we found in our patient. However, this variant is seen in 2 in 30,277 for patients in the Asian background, normal people, we can find this mutation. So because it is previously not reported so far, like the lab has reported it as a VUS. Because the missense mutation, we still don't know whether it's really significant or not. So the further slides, yes, please carry on.
So other available donor options were explored as the sister was also carrying the mutation. So planned for a matched unrelated donor, but there were limited finances. So we sent HLA of other family members. Father, who was a 6/12 HLA match with the patient. The donor specific antibodies were sent, which was negative, and his NGS was also sent. Awaiting that, we sent maternal uncle and maternal aunt's HLA. Maternal uncle was 1/12 match. Maternal aunt was 7/12 HLA match, and her NGS was also sent along with the DSA. So when the patient's family members were studied, as you can see in the table down, the patient, mother, father, and sister. The mother's sample, the DNA sample that we had was also processed for the same gene. And it was found that the mother who underwent transplant and subsequently expired was wild type for the above variant, that is this SRP72 gene, whereas the patient, the father, and his sister, all three had heterozygous mutation for this SRP72 gene, where glycine was replaced by arginine. So maternal aunt was 7/12 HLA match, whose NGS was negative for this mutation, was selected as the donor because the father and sister both had this particular mutation. So because there were so many queries whether to select the sibling or the father or the aunt, after multiple discussions, though HLA was 12/12 with the sister, but she had this mutation which was VUS in SRP72 gene, but she was phenotypically normal. So the question was, should we take her as the donor, or father who was a 6/12 match with the same mutation, should we take him as the donor? But finally, after multiple discussions, we decided that we will take a donor who does not have SRP72 gene mutation on the NGS, and we took her as the donor who was a 7/12 match with the patient, sorry. And subsequently, we sent DSA with the maternal aunt. Flow cytometric cross match, the T cell cross match and B cell cross match was negative. And also the single luminance antigen, where there were no donor specific antibodies found in class 1 as well as class 2. So he underwent a stem cell transplant with maternal aunt as the donor. The transplant details being conditioning regimen was Flu-Cy ATG with TBI. Fludarabine was 30 milligram per meter square per day for 6 days, from day -6 to day -2. Cyclophosphamide was 50 milligram per kg per day for 2 days, on day -6 and day -5. ATG, that is thymoglobulin, 4.5 mg per kg 4.5 mg per kg, sorry, over 3 days, day -9 to day -7, and 1 fraction of TBI, 200 centigrade on day -1. CD34 cell dose we got was 10 into 10 power 6 cells per kg with a volume of 190 ml. Date of transplant was 2nd November 2024. GVHD prophylaxis used was PTCY, cyclosporin, MMF. PTCY was 50 milligram per kg per day for 2 days, day +3 and +4. Cyclosporin was 2.5 mg per kg Q12H from day +5, and MMF also 15 mg per kg TID from day +5. Engraftment neutrophil recovery was achieved by day +20, and platelet recovery was not achieved. Complications he faced were febrile neutropenia with a Candida tropicalis sepsis, volume overload, probable hepatic veno-occlusive disease, coagulopathy related bleeding, acute kidney injury requiring dialysis, acute liver injury, probable sepsis or ischemic hepatitis or veno-occlusive disease. Briefly going through the complications, febrile neutropenia. On day +9, he had fever for which he was started on first-line antibiotics, cefoperazone, sulbactam. The workup was non-contributory. Day -5, the fever was high-grade, escalated to meropenem. Day -4, developed fever with chills, escalated to colistin. And the blood culture on that grew Candida tropicalis, for which he was started on caspofungin. For the seeding, 2D echo, USG abdomen, HRCT thorax were done, which was normal. Day +3, he had a fluid responsive hypotension, so antibiotics were further escalated to ceftazidime avibactam with aztreonam, teicoplanin, as well as liposomal amphotericin B, and started on granulocyte infusions. The sensitivity to Candida came as fluconazole sensitive, so it was changed to fluconazole. He developed a volume overload state on day +6 with weight gain, tender hepatomegaly, hyperbilirubinemia, and ascites, diagnosed to have hepatic veno-occlusive disease, started on dopamine, Lasix, and N-acetylcysteine infusion. Though the Doppler was normal showed normal flow in the portal veins. Coagulopathy-related bleeding on day +10, he developed hematemesis with epistaxis and melena, drop in HB, deranged coagulation parameters, required blood and product supports. Despite the products with diuretic cover, he developed worsening of fluid overload and tachypnea and had to be shifted to ICU on day +10. Intubated on day +16. Later, he started developing bleeding from the NG endotracheal tube, and product supports were continued with diuresis. And day +21, he was also administered 2 doses of Novo-7. Acute kidney injury on day +5, he was noted to have a rising creatinine value, for which cyclosporin was changed to sirolimus upfront, and all the drugs were renal adjusted. Day +16, when he was shifted to ICU, developed a non-oliguric AKI, and so started on diuretic infusion. Day +17, he developed pulmonary edema and had to be initiated on SLED or SCUF, and later became oliguric with refractory metabolic acidosis despite regular sessions almost daily of SCUF or SLED. DDs considered were ischemic tubular injury, drug-induced injury, or veno-occlusive disease. Acute liver injury progressively worsened. On day +16, he developed hyperbilirubinemia with transaminitis with hepatomegaly. The differentials considered were ischemic injury or sepsis or veno-occlusive disease. Finally, the family was counseled about the poor prognosis, and they opted for de-escalation of support by day +26, and he succumbed to the illness on. Terminal events were sepsis with multi-organ dysfunction syndrome, a picture of disseminated intravascular coagulation secondary to sepsis, and multifactorial acute kidney injury. I'll hand over to Dr. Nutan to summarize briefly.
So to summarize, this was a case of a 15-year-old boy with a significant family history of aplastic anemia in his mother, who has been diagnosed to have very severe aplastic anemia. And during workup, he was diagnosed to have a rare mutation, which was a VUS associated with aplastic, probably associated with aplastic anemia. We had difficulties in choosing the donor, as further workup revealed that even father and his sister also had same mutation. Finally, we chose his aunt as a haplo-identical stem cell donor, but we lost him due to transplant-associated complications. So this case brought us to certain questions, which we thought it's worth discussing those questions. So next slide. So the role of NGS, as Sir said, these are some new technical advances which we really sometimes think whether they are really boon to us or what, because the deeper we go, the more we find, and the more we find, until we know what to do with that more, we are stuck. So the clinical relevance of all these new mutations which we are finding, only time can tell us. However, ideally in such situation, it's the ideal thing would be to check those mutations, to introduce those mutations in animal models and to see whether they really develop aplastic anemia or MDS. So it's VUS is whether it's really benign. It is again a questionable, because Indian data may not be representative, as we have started using NGS in the recent maybe 10-15 years. And so we may not have reported those rare cases, and those mutations may be specific for the Asian population, may not be represented in whatever data is available. So it's important to report the rare cases also. Can we go to the next slide? So there are some more questions which we felt like, should we have taken the sister or father as they were phenotypically normal? However, knowing that the same mutation which has already been published to cause aplastic or MDS, it would not have been a wise choice to take sister or father. The other question was whether the reduced intensity conditioning should have been better, as the increased chromosomal breakage was there on the stress cytogenetics. The score was 18. However, current literature doesn't support this. If you have, unless the score is more than 40 or it's a typical of Fanconi, it's not recommended to reduce the intensity of the conditioning to prevent RRT. And if how should we go ahead if the stress cytogenetics has increased chromosomal breakage but not more than 40? As I already told, we should go for NGS. We should look at the NGS in those cases. And the role of testing ubiquitination of FANC-D2 by Western blot. The thing is, because it is the ubiquitination of FANC-D2 by Western blot is more sensitive and more specific than chromosomal breakage analysis. Though it was a gold standard for many years, chromosomal breakage analysis, the ubiquitination of FANC-D2 by Western blot is more sensitive and more specific. So those cases wherein we are in doubt, we should definitely go for this test along with NGS. Thank you.
Thank you both. Before we go to some of the questions that are coming up in the chat, there's just a few more things I would like to add on to what has been said. So the important things I think are, first is in terms of testing for Fanconi. Now all of us do testing for Fanconi anemia in a young patient, and the recommendation is that we do it till 40. Our standard method is, as Dr. Newton and Yash said, it is chromosomal breakage analysis. Now, if it clearly comes negative, you are safe. Or if it clearly comes positive, that means a score above 40, you are safe, because you know either way. But a lot of patients fall into that gray zone. And when they fall into that gray zone, it is very important whether you're considering transplant or whether you are considering immunosuppressive therapy with ATG, that you need to be 100% sure whether you are dealing with Fanconi anemia. And so the ways of confirming whether Fanconi is there is, as Dr. Newton said, would be NGS. The problem with NGS is it's going to take you some time. It's going to take at least 4, 6, 8 weeks before you can get that answer. Now, because you take that long time, some centers which have the technique of and the lab to do it, we would do either Western blot on skin fibroblast or an MLPA, because you can get those results within a week to 2 weeks. So in case you have a sick patient, you can actually proceed faster, knowing whether there is Fanconi or no Fanconi. So that is where both the MLPA and the Western blot come in. But your own lab should be able to do it in terms of getting it. Now, if we are sure it's not Fanconi, I think it is very important right now in India that a young patient, you should do an NGS to look for other inherited bone marrow failure syndrome. So this boy is a classic example of who has got no dysmorphic features, nothing to suggest a bone marrow failure syndrome, but we found this. Now, what are the telltale signs that would help you? One, of course, would be if you find, I think the strongest thing would be if there's a family history of aplastic anemia or myelodysplasia. If there is a family history, then you can be reasonably sure you are dealing with some inherited bone marrow failure syndrome, and so it's important to try and diagnose what that is. So second would be if you had a patient who presented very, very early. So the recommendations from the French is that if you had somebody who presented less than 2 years of age, you can be reasonably sure that you're dealing with an inherited bone marrow failure syndrome. So earlier age and a family history are what you would go at. Now, one of the big problems that all of us face in the clinic is that we order NGS, we get the result, and sometimes we don't know what to do with the result. And that is true because we need to remember that for the American College of Genetics to uh, classify a mutation as pathogenic, they should have seen a certain number of cases related to, say, aplastic anemia over a period of time in different populations, and then only it is classified. So, what would be considered a VUS now, probably 5 years down the line, will be considered as pathogenic. So, we need to remember that those classifications keep changing, and so we have to be careful about interpretation. Now, how do we sort of confirm? The best way to confirm, like Nutan said, is either using animal models or doing iPSCs. You can create knockout models and then see whether they develop aplastic anemia, but that is out of the realm of most labs. So, most of us go by understanding, is there a family history? If there's a family history, yes. Now, the second thing we would definitely look, I think in this patient was not done, was to look at telomere length. So a very short telomere length, less than 1 percentile, would again point towards the fact that you're probably dealing with the inherited bone marrow failure syndrome, and so you would consider going ahead with going ahead with testing and confirming and calling this VUS as probably pathogenic. Now, there are a lot of ifs, and I would say yes, we spend a lot of time discussing sister is HLA matched. She's phenotypically normal, and she's actually 2 years older, and she has not, her blood counts were normal. So, should we use her because she's HLA identical? Now, this SRP72 has got two different categories of diseases. One is a syndromic disease of either aplastic anemia or myelodysplasia associated with either sensory neural deafness or labyrinthitis. That's a syndromic SRP72. There is also a non syndromic where you can present with early onset of aplastic anemia and a late adult onset of myelodysplasia. So, if you have a donor who's also got the same mutation, and remember, this is an autosomal dominant mutation. So, because it's an autosomal dominant mutation, only a heterozygosity is enough to cause the disease. Unfortunately, in SRP72, what is clearly mentioned is that its expressivity in terms of the phenotype can vary even within the family. So you may have people, as example, in the father who is now 40 years old and has got the same phenotype but has not expressed it and is actually well with normal blood counts. So I think as we keep seeing doing more NGS and as we keep seeing more and more of these patients, we have to make a conscious call just because it's VUS. Because if you send it to any of the people to interpret, they will call it VUS based upon what the ACG says. But is it truly VUS or not? We will not know right now. So we have to go with history, family history, to make a conscious decision of whether this VUS is actually a VUS or not. And fourth, I think, is the question in terms of the transplant. Yes, we one of the big challenges, I think everybody will agree, when we do haploidentical transplants is sepsis. So this patient actually engrafted, but unfortunately expired due to sepsis. Both had candida and had bacterial sepsis uh, down the line, and regimen related toxicity in terms of veno-occlusive disease, and because of the VOD ended up having renal and hepatic dysfunction. So with this, we will close, and we've got about 10-15 minutes. So we will go to some of the questions. I will start with what is on the chat. So the first question was from Dr. Ranjit Kumar, the borderline sensitivity cases where chromosomal breakage came negative with NGS FANG gene mutation positivity. So remember that NGS is now the gold standard for diagnosing FA. And we have patients who are chromosomal breakage analysis negative or low but are NGS positive. Now we need to clearly remember that in India, other than FANG A, FANG L is the second most commonest genetic mutation in India. And in FANGL, many times the chromosomal breakage analysis may be normal or very low. So that is one thing we need to remember for India. So we need to confirm, and when we confirm if NGS is done and if NGS shows the mutation, you can be sure that you're dealing with the Fanconi anemia. Now, when we have Fanconi anemia, we generally tend to cut down the dose of cyclophosphamide. If we are using busulfan, if it's an MDS, we would reduce the dose of uh, busulfan also in patients with Fanconi anemia. Now, the second question is by Dr. Gupta regarding GVHD prophylaxis. Yeah, so it is a big challenge that when you have a patient who's on hemodialysis, then develops hyperbilirubinemia, then develops ARF, we have a big challenge in how to give the GVHD prophylaxis, and that is the problem that we commonly see. We end up cutting down on the doses of cyclosporin. Sometimes, if there is bad renal failure, we need to stop cyclosporin. We sometimes change over to less nephrotoxic drugs like sirolimus. So, that is a challenge that we face, whether it's aplastic or whether it's any other patient undergoing a haploidentical transplant. Now, the inheritance, it autosomal dominant, and because it's autosomal dominant, that is one of the reasons why we did not use the sister as the donor. Now, I think Rajan Kapoor has asked why was ATG used. Now, if you look at the data from Ami Discern, looking at haploidentical transplants in aplastic anemia, they have clearly shown that by using ATG up front, that is, so that means before the conditioning starts, if you use ATG, the risk of graft failure comes down. And so we have added on incorporated ATG into the conditioning for patients who are stable without active infection at the time of going into transplants. So, how far are we with proteomics predictions tools? I think we are quite far away. We need to remember, unfortunately, aplastic anemia is much more of an orphan disease, even in a country like India, because most of the focus is on malignant diseases. And because it's on malignant diseases, the focus on bone marrow failures is less. But I think more people are slowly starting. And so we hope down the line we should be able to have some idea in terms of proteomics or other prediction tools to help understand this. So, Dr. Gupta is asked again about ATG administration. What I said was, if you are going to primarily treat with ATG, and those who do not have a matched sibling donor, the alternate treatment would be ATG plus cyclosporin plus minus a TPO agonist. You cannot use that in Fanconi anemia. It will not work because it's an inherited bone marrow failure syndrome and not an immune aplastic anemia. It is only in the immune type of aplastic anemia where ATG will actually work. Uh, Views on PTCY reduction. People are looking at the 15 to 2, whether we can go down to 14 to 2 or 13 to 2. There is some data in in malignancies, but nothing much in aplastic anemia. We have looked at alpha beta depletion. We have done a few, but the incidence of graft failure is high. And two, we need to remember is, for us, the standard cost of a haploidentical transplant is 25 lakhs. And if we are going to do alpha beta depletion and an add back, then we are going to add another 10-15 lakhs to the cost. So we are looking at 35 to 40 lakhs, which is out for a lot of people. Uh, so there's a next question on how to proceed with cases where stress cytogenetics is positive borderline and NGS is negative. If your NGS is negative, you can be reasonably sure that you're not dealing with Fanconi anemia, and so there you would treat it as a aplastic anemia. Now, when the NGS is negative, that means you have also, if you have done a good 80 gene panel, you are on, have ruled out all other inherited bone marrow failure syndromes also. And so there you would look at whether you want to go for a MATSIB or whether you want to go for ATG, depending upon what is available. Now I will just move on to the question and answers. So patient is FANC-C with features of FANC-D, fully match sibling who's FANC-C positive. No, you cannot. Even though without any phenotypic features, if the fully matched sibling is FANC-C positive, you cannot use that donor for transplant, because we remember that in the same family, the phenotypic presentation of aplastic anemia and MDS can vary between two siblings who have the same mutation. So you cannot take cells from a donor who's got that same mutation and give it to the patient. Would T cell depletion have prevented TRM in this case? Good question. We have to balance the cost and rejection with T cell depletion. So if you're going to do an alpha beta depletion, like I mentioned, we are looking at about 40 lakhs. Yes, that may have reduced TRMs to a certain extent, because the whole VOD that occurs with the use of cyclophosphamide comes down, but a lot of people cannot afford that. So all VSA with IBMFS, should we proceed with haploidentical transplant? Is that an institution protocol? So anybody with inherited bone marrow failure syndrome will only get cured with a transplant, period. You can use drugs like danazol to help try and improve the hematopoiesis, but that is again not curative. So in our institute, we would definitely consider anybody with the IBMFS, we would consider with the haplo as first line if a matched sibling donor is not available. Now, why TBI in conditioning? Yes, in haploidentical transplants, definitely the addition of 200, and now the recommendation actually is 400 centigrade of TBI to reduce graft failure. Is there the 400 centigrade does not add to VOD? We do not have much data on secondary malignancies in standard haploidentical transplants, because we do not have patients who have been alive for 10-15 years. We clearly know from the Fanconi anemia that there is a risk of secondary malignancy, both related to the disease as well as related to the presence of chronic GVHD. So all this will add. Now, for other aplastic anemia with IBMFS, we do not know the answer, because we do not have that much of a large follow-up to say that it will work. Then, so these are in question and answer. So in conditioning for Fanconi anemia, what we generally do is we reduce the dose. So in a standard aplastic, we would use 120 milligram per kg of cyclophosphamide. In a Fanconi anemia, we would actually reduce it to 20. The Brazilian group have gone up to 60 milligram per kg, but we would not use the standard doses of cyclophosphamide that we use in aplastic anemia. Even post-transplant, if you're doing a haplo, we generally do not use the 50 into 2, but we use 25 into 2 in patients with Fanconi anemia. Now, I think Dr. Pratik has asked a question of if there is a short telomere length but NGS is negative, it is a very difficult one. I would treat it as an inherited bone marrow failure. So I would only offer transplant. Now, as long as we are clear that it is not a Fanconi, for most of the others, you would use only standard conditioning. There is a bit of controversy about DKC, but DKC generally gets picked up on the NGS. So you would treat it as a you would not give ATG just if the telomere length is low. When we say low, we need to remember that 50% of aplastics will have shorter telomere length. That is not what we are talking about. We are talking about a less than 1% telomere length. That is very short telomeres. Very short telomeres definitely is inherited bone marrow failure syndromes. Can Fanconi anemia patients present with PNH positivity? Very, very, very unusual. Although I should say people have talked about case reports where there is. So generally, I have not seen a PNH below the age of 9 to 10 years. Most of the PNHs I've seen are beyond that, and Fanconi occurs less than more. But anybody less than 40 with aplastic anemia should be tested for Fanconi anemia to make sure that we are not dealing with the inherited bone marrow failure syndrome. So I think we are 56 minutes, 4 minutes to the hour. I think if there are no further questions, I would like to thank Yash and Dr. Nuthan for presenting these cases and for bringing out a discussion. I would thank all of you participants who have taken part. I understand there's more than 250, and for all those who are putting in these questions. We hope you continue with the same enthusiasm for every subsequent webinar that we have. And now I will hand it over to Dr. Arun.
Chris, Dr. Joseph John also, sir, please add some words.
It is it's a pleasure to be here. We also learn from each other in the process, and the case has been discussed well and gave a fantastic overview of aplastic anemia, the challenges of finding the donor and actually getting in the molecular level. And I'm happy to see this 240, 50 students from all over the country joining up together. That itself is a big boon for all of us. So many people are interested in it. And thank you, Intas, for organizing and taking this initiative.
Thank you, sir. And I, Arun Chedda, Vice President of Intas Pharmaceutical, would want to express my sincere appreciation and sincere gratitude to all the participants who have joined us today for this inaugural episode of our Blood, the Life Savior web series. We extend our heartfelt thanks to our esteemed course director, who is a well-known personality not only in India but in the abroad also, Dr. B.G. George and Dr. Joseph John, for their vision and dedication in initiating this valuable web series and series to life. We are grateful to the CMC team for presenting such an engaging case study. Special thanks to Dr. Yash Patel for presenting the case and Dr. Newton for her insightful dissection and in-depth analysis of this case. And once again, thanks to uh, Dr. B. George, who is the professor and head of the Department of Hematology at CMC Vellore, for their expert comments on this beautiful case and which will be very invaluable knowledge and guidance to all the DM and DNB students. This series promised to be a rich source of information for all the DM students, and we encourage you to stay tuned and join us again on February 19th 2025 for the next episode of this Blood, the Life Savior. And till then, stay safe and stay healthy. Thank you all for your participation. Thank you. Thank you very much, sir. Thank you. Thank you. Thank you, sir. Thank you, ma'am. Thank you. Thank you, sir.
Support.
Team.
Yes,
You
ma'am.
can close the
Those?
meeting, please.
Sure, sure.
Thank you.
Thank you so much.
Right.
Thank
Yes,
you
ma'am.
all.
Good night.
Thank you very much.